Hello, Yewamide. Hi, everyone. Hi. Hello.
Hi.
Good evening.
Good evening, Dr. Choma.
Good
I
evening,
hope the
Dr.
internet will be kind to us today.
I hope so. I hope so too. I hope so too. Welcome, welcome, welcome. Okay. I think we have people online right now. More people are joining in. Okay. So, good evening, everyone. Today we're going live with Dr. Zainab Yaro. She's a passionate child and breast cancer advocate and medical doctor. She's the founder of Saving Little Humans with Dr. Mims, a platform that creates awareness on child health and wellness issues. And she also runs an online concierge for pediatric consultations for non-emergency medical conditions. She's a pediatric CPR and first aid instructor, and she offers it free to orphanages and public schools. She's the author of My Little Humans, a personal health record, a journal and a guide on caring for children from birth to 5 years. And she's a co-founder of Progeny Cerebrum, a unique community that provides one-on-one mentorship and career advice to medics in training. Welcome, Dr. Zainab, and thank you so much for honoring this invitation. This is actually a
I
rescheduled
know,
live.
right?
Yes, yes. Welcome, everyone. Um, so today we're going to be talking about caring for preemies, what we need to know, and Dr. Zainab is going to also talk a little bit about her book. But what I want to do, we're going to sort of apply it to this topic. So please would you just explain to our viewers what a preterm baby, what a preemie is?
Okay, so like I always like to refer to them, the preemies are the little humans that were born too soon. So by way of definition, it's usually the ones that are born before the 37 completed weeks. That's when you count from the last menstrual period. That's the first day of your last period. And it's usually about, 259 days. So they're actually classified differently. But then it's always said that irrespective of their birth weight, a preterm is a preterm. Because you can have a preterm that was born to a mother who was diabetic in pregnancy and the baby is, heavy enough to be termed a term baby, but then a preterm is a preterm based on the gestational age. So, you
Mm-hmm.
have the mild, moderate, and then the severe preterm, where you have the less than 28 weeks at the severe preterms, 32 to 34 weeks at the moderate ones, and then you have the late preterm or the mild preterm, which is from 34 weeks to anything just, before 37 completed weeks. So these are, what we classify as preemies.
Preterm. So could you just explain to us what the cause is? What could put people at risk of having their babies come earlier than planned?
It's actually it's still baffling because preterm births, account for majority of infant mortality. So you expect that we should know all the causes by now, because even in Nigeria, 40 to 60% of mortality cases are caused by preterms and all that. So half of the cases, like 50%, causes are unknown. While the other 50%, is shared amongst a different number of things. So you could say what we know now is that genetics plays a major role in preterm deliveries because you see instances where, let's say, as a female, my sister had preterm, birth, a preterm birth. The chances are quite high for me to have preterm birth as well. If my mother had a preterm delivery, I have higher chances of having that. If me myself was a preterm, a preemie, I have, a higher chance of having a preterm delivery. So this shows that genetics actually plays a huge role. Another thing is the fact that, they just term it as multifactorial. Like a lot of factors can come into play. You're talking about maybe socioeconomic status of the mother, poor antenatal care, poor nutrition. So they now went on to like just classify. As in medicine, every other thing is you try to differentiate the factors into different, groups. So with the preterm, births, you can classify the risk factors into the maternal factors, the fetal factors, the placental factors, and then the uterine factors themselves. So for instance, in the maternal factor, we're looking at things like chronic diseases like diabetes mellitus, you're looking at chronic hypertension, you're looking at things like urinary tract infection in pregnancy, malaria in pregnancy. Then I talked about poor nutrition in the mother, poor antenatal care, low weight in the mother as well. Mm-hmm. These are all maternal factors. Then fetal factors, you're thinking about intrauterine growth restriction, congenital anomalies in the child, some sort of fetal distress. This can all predispose to a preterm delivery. Then in terms of placental factors, you have things like placenta previa, when the placenta is abnormally placed close to the opening of the cervix. So, that can predispose to preterm birth. Placenta abruptio, when the placenta, prematurely detaches from the uterus, because that shouldn't happen until when the baby is out. Sometimes you have to manually, bring it out. So this could occur before delivery, and this could lead to preterm, birth. Another placental factor could be when you have something like chorioamnionitis, it can be classified as a maternal factor, and sometimes a placental factor as well. Then uterine factors, you have things like bicornuate uterus, where you have abnormally shaped, uterus and all that. You have incompetent cervix. So there are a lot of factors, but then we try to classify it into whether it's maternal, fetal, and then it's very important that we know the cause. Most times in the first pregnancy, you don't really know the cause, so it just happens. For instance, like incompetent cervix, most times the first pregnancy is lost because we're unaware. There's no way to actually predict that, okay, this person has an incompetent cervix unless the person has been pregnant. So most times you want to know the cause of this preterm birth so that you can avoid it, especially if it's a modifiable factor, in the next pregnancy. So by and large, these are the factors that, seem to have been identified, in causing this preterm birth.
Okay, sorry, please, I'll just take you back quickly. Just for the for people watching. So chorioamnionitis is actually an infection, isn't it?
Yeah.
Okay. So so what are the things that how are they cared for? Could you just take us through, because I think one of the challenges that parents have, even though the onus is on the health provider to carry parents along, is not really understanding what exactly is going on, how their child is being cared for. So could you take us through the sort of treatment, the sort of care that these babies are given when they're born?
Well, the truth is, even before the baby is born, when you anticipate a preterm delivery, the first thing you have to do is to counsel the parents. You have to carry them along. You have to explain to them what to expect. Some of them think that, oh, I'm going to have a baby and I'm leaving the hospital in 2-3 days, So you have to make them aware from the get-go, even before the baby is out, that, okay, you're in here for the long haul, and then a number of complications will arise, so you should expect these things. I think when they're mentally prepared, it makes it easier for them to transition from, okay, my baby being in utero and then my baby coming out too soon. And then it helps them, anticipate these problems. And if these problems don't come about, then yay, they're happy. So I think first and foremost is we have to inform the parents that your baby is coming out too soon, and then we're going to expect some problems. It might not necessarily come up, but then, that's one. Secondly, we always say that the uterus is the best incubator, right? So if you have a pregnant woman that's been doing antenatal at your center and you preempt a preterm delivery, fine, there are things you can begin to do. Sometimes you try to give tocolytics to quiet, the uterus to stop it from contracting.
What are tocolytics?
I was about to explain that. So tocolytics are like drugs, that they give to quiet the uterus, sort of. Because the uterus, once it begins to contract, that means the baby has to come out, okay? So when you give tocolytics, you're trying to say, okay, calm down, it's not yet time, So sometimes it works, sometimes it doesn't. So if you've tried all these maneuvers and it's still not working, then you begin to mature the lungs of the baby while the baby is still in utero. Because one of the main problems, faced is the lungs being immature. So you want to begin to mature them by giving steroids. You give the injection to the mother, 12 hours apart, 24 hours before, because you want to delay that delivery as much as you can. Now, we always advise that if you're in a center without a NICU, that's a neonatal intensive care unit, it's supposed to be level 3, but, well, in Nigeria, we make do with what we have. So if you don't have a NICU where you have a functional incubator and people on ground to manage this preterm, it's best to refer the mother with the baby in utero. We always advise that don't, no, maybe because you want to make profit, you want to make money, or oh, this patient belongs to me, you want to do the cesarean section in your own facility and begin to transport that preterm to another facility. You know, those are a lot of factors that are against the preterm. So if you, like, as you know, most labor wards, most theaters for cesarean sections are always stationed very close to the NICUs, very, very close. There's a lot of proximity because you want the baby out and in the NICU, okay? So imagine now transporting a baby from this, and then a lot of factors can come up. There could be traffic, the car could break down, the ambulance might not be available. So we just want to make sure the baby is in a center where it can be cared for. So now, before delivery, I told you the preparation starts before delivery. So you're counseling the parent, you're trying to mature the lungs, you're getting everything ready, you've informed the neonatal unit that the preterm is coming in, and then you have the pediatric team informed. So most times when they inform us, we want to know what the gestational age is. So pediatric team, we go over to the O&G section and we see the mother, we go through her file, and we want to find out, is the age of viability something we can handle? So like in the center,
sorry, language.
Okay, yes. Thank you, Chief. So in the center where I worked before, right, what we do is we go to the obstetrics and gynecology unit where the pregnant women are. We go through their case notes. We want to find out the gestational age. That means how long has the pregnancy been? Yes, is it in weeks? You know, whether it's in weeks or in months. So we want to know. So in my previous center, the acceptable age was 30 weeks. Anything less than 30 weeks, we refer, because it was a tertiary secondary center. So anything below 30 weeks, we refer to a tertiary center. No matter the pleading and the begging of the parents, we know what is best for that child, right? So we always want to move the mother to a tertiary center. So first things first, we move there, we check the case notes. What was the indication for the, you know, what could be the cause? Is it, because for instance, now if it's chorioamnionitis, that's infection of, you know, the fluid, the sac and everything surrounding the baby. If it's that kind of infection, we're already thinking, oh, this baby is going to need antibiotics once the baby is out, right? If it's due to multiple gestation, because sometimes when you have twins or triplets, or anything above one fetus, you know, that's another risk factor for preterm delivery. So we want to know how many babies are there. So we prepare, you know, the incubators for those babies. So basically, we're just, you know, fishing for information to help us prepare for, you know, this child. So that's another step we take. Now we're there, we're in the theater, the matron is there, the midwife, the pediatric team, we're there, depending on how many babies. If it's something one person can handle, one doctor is there, the O&G team, they're there. Now we wait, right? So everything is in their court until the baby is out. So we wait, we're gowned, everything, the radiant warmer, there's something in the theater, because one of the problems they face is temperature regulation, right? So one of a must-have, all of them, they know me in the theater. Once I go there, I just turn on the radiant and I put my hand to feel whether it's warm or not. So the radiant warmer is on, we have everything for suction, for that's taking out fluids, you know, from the baby's nose. We have all we need to clamp the cord, everything, we're ready. So we wait, the baby is out, we bring out the baby. We don't waste as much time as we do with the term infants where, oh, you clean them, you know. This, when the baby comes out with, you know, that thing on their body that looks whitish, like some sort of wax, we call it vernix gaseosa, we leave it on them. That is the ideal. We always have this fight with the midwives because they're so quick to want to clean with the olive oil, you know, that you know, form some sort of coat for them to help with their temperature. In other parts of the world, they even use things like Ziploc bags, those bags you use in freezers to store your frozen food. They actually put these preemies into those bags to preserve the heat. So once they're out, you know, put them there, you wrap them up, put on a hat, we move them. In other centers, they move them in an incubator from the theater to the NICU. Now, once they get there, you're checking their saturation oxygen, because, like I mentioned, they have a problem with, you know, respiration and saturation. So you're checking their oxygen saturation. You take them there. They're in the incubator already. You're checking their temperature. So all those probes are on them, checking temperature, checking oxygen, and all that. And then they're being kept warm. Now, when we take them there, depending on what, you know, what the history was like, if we're suspecting infection in the mother, most times we would have written our treatment sheet, we're going to start them on antibiotics, we're going to start them on IV fluids, what everybody calls the drip, because you don't expect these preemies to start eating, ab initio. So, yeah, Tiku Forgotten is saying we need to discuss the ABGA score. Well, I didn't want to go too technical on, because, basically the ABGA score isn't something, most times the parents are aware of, because ABGA score, because I just want to give information that I feel the parents, should be aware of.
Yeah.
Because ABGA score is a scoring we use, medical professionals to assess, how well the newborn is doing outside the womb postnatally. Now that the baby is out, because when they are born preterm, they might not necessarily have all it takes to survive or do well on their own outside the womb, where they were, that cocoon. So the ABGA score is what we look at. There are 5 parameters actually. It was an anesthesiologist that came up with it, the scoring to assess children, the ones that need resuscitation. Okay, so based on their score, that does this baby need resuscitation? Is this baby fine? Do you anticipate other problems? So once the baby is out, you're assessing. We have the 1st minute, the 5th minute, and then the 10th minute. The 10th minute is usually for prognosis, to see how well the baby is going to do in the future. So we look at 5 parameters: the appearance of the baby, you assign scores of 0, 1, and 2. Is the baby pink? Is the baby, does he have blue extremities? That means the oxygen, isn't really. And sometimes when you have just extremities, it might just be the cold that is making, the palms and the feet look blue. And then, or is the baby just, pale? Then you have the pulse. You're checking for the pulse. We count, is it less than 100? Is it more than 100? Things like that. Then you look at the activity of the child. Is the child just limp? Some babies come out and they're very vigorous. They're shoving. You're trying to cut the cord. They're grabbing. So you're looking at the appearance, the pulse, the activity, respiration. You're looking at their respiration. You're counting. Then you're looking at the grimace, because once they come out, they have fluid in their nose and all that. So you use a suction, like a tube, to try and suck out the fluid. So once you just put it in, a baby that is very conscious and active will squeeze the face because it's uncomfortable. Some will just make some are just limp. So based on the scores we have, we describe it as asphyxia, whether this baby needs some sort of resuscitation or not. So that's basically what the ABGA score is. So most times on their file, you see the ABGA score for the 1st minute, 5th minute, and 10th minute. Okay, so that's there in the theater, and that's mostly for the medical professions. So now we're in the NICU, they're there, so we're looking at temperature. They have a problem with temperature, like I mentioned. Then feeding, we don't rush to feed them immediately, because a lot of things are premature, In their stomach, they lack some enzymes like lactase, is the enzyme that breaks down that component of milk, Then we have the gates that close the stomach. So once you eat, there's a gate there called the sphincter that closes off, where the esophagus, and that's the gullet, and then the stomach. So theirs is quite weak. So once they eat, it doesn't really stay down there. It tends to come back up, and then they have some sort of reflux. And they have so many issues. So most times we delay feeding them, but we give them fluid. Because another problem they have is sugar regulation. Sometimes they have hypoglycemia, that's low sugar level. Okay? So most times, and then once they're out, obviously we check their sugar level at that time to make sure it's not too low that we have to now correct, using a sugar solution. So they're there, and then you start your antibiotics if need be. And most times, depending on how preterm they are, or how much maybe their birth weight, we tend to put them under phototherapy as prophylaxis. Prophylaxis is you're trying to prevent something from happening. Because we envision so many things, because they have a problem. Their red blood cells, normally a newborn, their red blood cells, in an older person, the red blood cells last longer, up to 120 days. But in the younger, in newborns, it lasts less. So it breaks down quickly. And once the red blood cells are breaking down, you have a component of them that's what brings about that jaundice you see. So most times we already preempt that the lower their age, gestational age, the more we envision they might have jaundice. So most times, it varies across centers actually. We put them under light. So that light even helps with the warmth, and then it helps prevent, jaundice. So most times they're just monitoring them. You're checking. And then some of them, I talked about saturation. Some of them might need oxygen supplementation, either with just a face one, or some of them will need what we call a CPAP. So that one is a bit different, because like I told you, they have a problem with maturation of the lungs. So you want to make sure that the lungs stay, because the lungs can easily just collapse So you want to make sure that the lungs they stay open. So that's what the CPAP does. So it's something like a mask you put on, this attached to their heart. You put it on, and then you see like bubbles going, but then just helping them with their breathing. Cranial ultrasound.
No. No, please, let's not go
Chief,
there. Please. This is
Chief,
actually for parents.
I'm telling you, Chief, like we'll turn it into like a morning presentation or CME. So yes, we do all this because they're at risk of what we call intraventricular hemorrhage. So inside, their brain, sometimes they tend to bleed. So most times you want to do, ultrasounds. Obviously, you put on lines, but I want to stay true to what we practice here in Nigeria, okay,
Yes.
in as much as, and all that. So we put them on the CPAP, and then most times in centers, we administer what is called the surfactant. Now, I told you that the lungs, like those, they're tiny, like the lungs, when you look inside, it looks like tiny grapes. It's called the alveoli. That's where the gaseous exchange happens. So oxygen comes in, carbon dioxide goes out at that point. If you're a biology student or a chemistry, you will remember all of this. So at that point, it's supposed to remain open like this, not collapse. Because once it collapses, then, all this exchange can't happen. And once there's no oxygen, the brain begins to shut down. And once the brain is completely dead, the person, is gone, because the brain is the powerhouse. So they give them what is called surfactants. And these surfactants are very, very pricey. They're very, very expensive. You commonly find them in the private settings, but in the general settings, to be honest, if we have parents that can actually afford it, then we call some of the reps we have on speed dial, and then they bring it to us. So this is another thing you'd want to give them. So basically, it's like their care is round the clock, because they have another thing called apnea of prematurity. That means at some point their breath will just cease.
Stop breathing.
Naturally, even normal term babies tend to have periodic breathing at some point. They could just be breathing and then they just cease for a while and then pick up again. Now with preterms, it's actually worse. So you'd want to keep them, they're supposed to be on apnea monitors. Because like in the center where I was, the incubator section was way like in one corner, and then the nurses section was another corner. So every time I'll tell the consultant, I was like, sir, I was like, it's God that is saving these babies, because imagine if a baby goes into apnea, how do you know? There was a time I'd finished rounds, I was even going to the call room, but then I think something brought me back to the neonatal side, to the incubator side, and I came there. This baby wasn't in the incubator, right? She was a preterm, but then we had weaned her out of the incubator. That means we had gradually brought her out. She had graduated from the incubator, and she was in her cot. And most times they're covered. That's why I always advocate. They shouldn't be too covered up so that you can actually see them. And I don't know, something just pulled me there. And it was just right there in the corner. And I went there, and I opened up, and she was gray. Like from top to bottom, this baby was gray. So luckily, I just rushed her to the resuscitator, because it's right there in the middle. And, we just began to resuscitate, and then she picked up. So I kept, for the longest time, like I said, I was on call that day, I kept thinking, what if I wasn't there? What if something didn't pull me back to check? So ideally, they should be on, apnea monitors, because what it does is whenever their breathing ceases, the alarm goes off, and then you rush over to try and resuscitate them. So we're looking at their, like I mentioned, feeding, temperature, their sugar level. Then you're looking at their heart, because sometimes, because they're born too soon, there's something called, most times you hear that this child has a hole in the heart. Because once the baby is inside the stomach, their circulation isn't the same as the adult, because they can't breathe on their own. So they get their oxygen from the mother through the placenta. So they have holes. God designed it that way. They have holes there that helps with their circulation and that oxygen. But once they come outside to the outside world, those holes are supposed to close. Once they take in that first breath, the pressures change, and then those holes are supposed to close. But then with the preterms, it doesn't really happen that way. So sometimes that hole persists. So this is another thing you have to keep monitoring. Sometimes you need to have an echo. That's to check. There's a kind of scan. You check the heart, check the holes. You see whether blood is going back and forth and all that. So they actually have a lot of problems. And like I mentioned, because the red cells are breaking, most times they have what we call anemia of prematurity. So most times and then you're taking samples for various tests. So we always have a chart where we write there's a limit of blood sample, volume of blood you can take. Because you see some of the moms will be crying, they finished my baby's blood. But we have a chart where you cannot go beyond this volume in a day for that preterm. Because we're already battling with, they don't have enough blood, Don't get it twisted. The quality of blood is good because it tends to be actually very high in newborns. In adults, you can have PCV, that's a packed cell volume of maybe, let's say 33, and that's fine. But in a newborn, when you see 33, that's a problem. You should be in the 40s, okay? So the quality of blood is good, just that sometimes the volume, like when it begins to break down, then you run into issues. So sometimes they need blood transfusions. And their veins are so tiny. So you're giving them blood, you're giving them fluid, you're checking their sugar, you're checking their temperature. You can't feed them
You're
because
checking their
you run into
intake
problems.
every day.
Yes, you have to chat. We do that for
Yeah.
all newborns, but then for
Yeah.
them, you're very specific because you're checking in what they're taking in and what they're bringing out, the urine amount, because there has to be a balance.
Yeah.
So, and then every day you're increasing the fluid. In adults, you can just say, give 3 liters over so start, But in children, it doesn't work that way. Then in preterms, it gets realer than that, You have to calculate based on weight and their age. If you're starting day 1, you're starting at 7 mils of intravenous fluid per kg. By day 2, you're going to 80 mils per kg, like that. And then based on how they're doing, you either reduce it or, and then you're checking their blood. You're checking the electrolytes, salts in the blood. You're checking so many things at the same time. And then at the same time, you have to deal with the mother as well, emotionally, mentally. It's not, I remember then when I come to the neonatals at the incubators, I'll see the mothers, they'll be looking depressed, I'll say, madam, what's the problem? Your baby is fine. Is it this box that is what, Until I had my own son, and then he wasn't preterm, but he needed to be in an incubator. I remember the first day I was real there to see him. I felt so bad because I was like, oh my God, he looks so lonely, Other babies had their mothers, they were doing the kangaroo, we're getting to that. And then he was just there alone, in the glass, So I was like, oh, so this is how they felt. So you have to talk to them to help them mentally. And then actually the onus is on the nurses because they spend more time with them. They spend more time with these babies. And most times, when a nurse tells me that, doctor, I think you should check baby so and so in incubator too. I always, hi, Sabi doctor, I always listen to them because they spend more time with these babies. The doctors will come in the morning, you do your ward rounds, you breathe in, you breathe out, and that's that. You might not even come back in there again unless, like especially for the consultants, but us, like we stay for a while, we go out, come back in. But the nurses are there constantly. So if a nurse or a mother tells you, doctor, this baby isn't as active as she was, then you better listen to them. Because with preterms, they can change drastically. So their care is multifactorial, really. So many things. When you look at the problems we expect to encounter, then you think about the care you're supposed to give them.
So I'd like to find out, for parents, what are the things that, because another thing that will most likely be going through is the feeling of helplessness. If this child was in my arms, at least I would do something. Now this child is in this ICU, in this box with all these tubes, and what do I do? What can I do? What are the things that parents can do to help their child survive?
So what we tell them is initially, like I told you, we should have counseled them in the beginning that this is what they should expect. You won't be going home anytime soon. And especially in the north, we have issues because of the naming ceremony, because that's the time you get gifts and money and all that. So sometimes by that 7th, 6th day, they're telling you, doctor, I want to go home. Are you going to have a naming ceremony with a baby who isn't well, who isn't strong enough, right? So we explain, and then they expect that it's supposed to take the normal, course. Like, I have a baby, I should be able to breastfeed my baby almost immediately. We have to explain to them that these babies are born too soon. They don't even have mature reflexes, like the sucking reflex or the swallowing reflex is not mature enough. And then they don't even have the strength, their muscles, are not strong enough to breastfeed. And then the small energy that they have that we want to conserve, we shouldn't be expending it. Yes, we shouldn't be expending it, with, sucking. And one of the core, coordination between reflexes for survival is breathing and swallowing at the same time. Once a baby can swallow and breathe at the same time, that's one of the core things we look at for survival. So we have to look at the preterms by not be able to coordinate that. So we explain all that to them. Now, we have to make them part of the management. For one, we have to institute the kangaroo mother care. I know it's not very, this thing here in Nigeria is not very, it hasn't been really adopted and adapted,
But it's cheap.
Yes, it's cheap and then it's readily available and then the effects are tremendous. They're very, very tremendous when you look at the effects. So with that, and then the parents feel involved. In other parts of the world, Dr. Nora is here. I'm sure she will tell you that in the US, the fathers are involved in kangaroo mother care. This makes them feel involved. Because like you said, they feel helpless. But then
Sorry,
if
please
they feel
explain
like,
what it is, please. Sorry.
yes,
No,
so kangaroo mother care is, basically how, the kangaroos in Australia, they carry their young ones in the pouch in front of them. Now, when they keep them there, there's warmth, there's bonding, all those feel-good hormones are there, it's being exchanged. So people researched and saw that this can actually be adapted in humans as well. And then it brings about a desirable effect. So what happens is, especially for the preterms, once the mother comes in, we always schedule maybe a certain time of the day. She comes in and then she's bare chested. There's no cloth or anything, it's just skin to skin. And she puts that preterm there, and then there's usually there's some, the types of carriers you use that they
wrapped.
sell, the wraps. So this one you can use anything wrapper as long as the wrapper is clean. We also tell the mothers they wash it every day. You come, tie it around, not too tight, just snugly, for the baby to be on their chest. And the baby is just there. Now, your heartbeat is what the baby has been dancing to in utero. Your baby has been used to that rhythm in utero. So imagine now the baby is out, the baby is confused, it's a new world, it feels harsh, it's cold, it's bright. And you put the baby back there, and the baby is listening to that rhythm all over again. There's warmth. We're talking about skin flora, the friendly bacteria that is on the mother's skin, being transmitted to the child. There's bonding, okay? And that also helps the baby with regulation of that temperature, because that is a huge problem. People are not aware that just that temperature can actually kill a preemie. Once the temperature drops, a lot of things will begin to shut down inside the baby. And that can actually kill. So you'll be wondering, oh, this baby was fine, baby was strong, what happened? Just temperature. Because they lack what we call the brown fat. And the brown fat in the body is what helps with regulation of your temperature. And what you don't know is that newborns, even term babies, don't know how to shiver. That shivering you have is a reflex, like a mechanism to try and get the body to generate heat so that you get warm. And then the hair in your body begins to stand, and they call it goose pimples or goosebumps. The hair is standing to trap more heat, around the skin to give you warmth. So kangaroo mother care, it's so effective. Like I said, it's cheap. All you need to do is be clean, and then the mother can take part, the father can take part. And that's basically how we try to get them involved.
And
Another
it
thing
can
we
also
do
calm
is,
their anxieties as well.
yes, it
The
calms their
parents'
anxiety
anxiety.
because they can hold. Yes, and then we try to get them prepared for breastfeeding. We tell them that this doesn't mean your baby is going to breastfeed, but we need you to, think positively, not be stressed, because the more you're stressed, the milk won't come in. So eat well. By the time we tell them that if you don't eat well, your milk won't come in, and when your baby is ready to breastfeed, there'll be no milk. There's a change, because you see at least this is something I can do for my baby, okay?
Yes.
So they begin to smile, they begin to look happy, they begin to eat well, and get good nutrition. So basically, we just try to carry them along. A lot of times I tell, some of the interns I've worked with, they'll just come and say, oh, mommy, this and that, go and get this bottle from the lab, we're going to take sample. And you don't explain to them what it is for. But the moment you begin to explain to them, oh, we're suspecting your baby's sugar is low, we're going to check this, and that, they're involved and they know what to expect. Not that you just keep the baby in the incubator and then you just tell them, all right, madam, come and do this, bring diaper, bring this, and you don't explain anything. We need to calm their anxiety and carry them along.
Okay, so I was going to go to hunger cues, but let me just ask based on also a question that someone asked. So, what informs the decision to at what point can the baby be discharged from the neonatal intensive care?
Well, like I said, there's no set, time to say this child is going to stay. A child that you thought, okay, this child was a mild preterm, this child shouldn't stay that long with us, then we begin to run into problems. So one thing I've learned in practice is never tell a mother that you're going home on so day. They will hold you to it. Even if you're not the one on duty, they'll say, Dr. Yaro said I was going home in 3 days, so they expect to go home. So first of all, you have to tell them that we don't know when your baby will be going home, but we're going to do our best. Don't make promises. We're going to do our best to make sure, baby lives, in good time. Now, when you look at the things we're trying to manage, you now begin to think, oh, this might be the criteria for the baby to go home. One, once that baby, we feel that baby can maintain body temperature on their own. Because when you talk about weaning, it's not something you do abruptly. You try to reduce, the temperature, adjust the temperature and see if the baby will do well. on that temperature. So once they can regulate temperature on their own, that's one cue. Then once they're gaining, because every newborn and preterms as well lose some percentage of their birth weight, and then they begin to regain it again afterwards. So once they steady increase in weight, the steady weight gain, that's another criteria that we look at before sending
But
them
up to
home.
what point though? Is there
Sorry?
up to what point?
No,
Is
like
there
what
like a
happens is it depends. Like it varies across centers, right? In some centers, they'll tell you that once that baby has gotten to, let's say, two, some like centers, they'll tell you 2.5. They'll tell you that 2.5, the baby can go home, or they'll tell you 2.2. Some centers will say 2, but then it has to be very frequent, like follow-up has to be very frequent. So for weight gain, it's not a set, because we've seen baby this. First of all, we have a certain weight for bringing the child out of the incubator. Then you now have another set weight for taking the child out of the neonatal unit and send the child home. Apart from which, then we have to look at the feeding. You're not going to send a child home who has not started taking anything orally. I told you we delay feeding orally. We start them on IV fluids, that's the drip. And then what we do is we prime, we prepare their gut gradually. So we can give as little as 1 meal. That's like almost a drop of milk, like every 2 hours over the span of 1 day. So in a whole day, they might just have just a tiny amount of milk, but then it's just priming their gut. Before gradually we increase it, most times we do what is called a gavage. So what the nurses do is the feeding tube is there, is put through the nose into the, it goes all the way into the stomach. So because from the nose, it goes down into the stomach, right? And then what they do is they hold the syringe upside down. They don't push it in. They let gravity take it in. So it's called the gavage. So before then, we would have done a lavage, that's pushing in sterile water to try and see if there's anything in there. They push it in and then aspirate, that's bring it out to see if it's clear. If it's not clear, we don't feed. We wait again and repeat it another time. So once it's clear, we begin that feeding little by little, until we now feel that they're gaining enough weight and they're more active, and then we now begin to put them to breast gradually. So because you don't expect a mother to do that at home. So unless they can actually suckle by themselves or using cup and spoon, and then they're tolerating, because when you give them that milk, you're looking at, is the stomach beginning to swell? Are they moving ball? They're having their stools normally. So you're checking all these things to see if, this child is tolerating the feed. So if the child is not feeding well, that child is not going home. In other parts of the world, even in term babies, once you've been admitted, you don't send the baby home if breastfeeding has not been established, if that's what you've chosen. Because most times they give you choices. Do you want to breastfeed or bottle feed? But here, for the preterms, we have to make sure that child, is feeding well. Another thing we have to look out for is the respiration. Is this child breathing well on their own? Are they maintaining some sort of, saturation, and acceptable saturation on their own? So we have to make sure that is there as well. You look at that, then you look at there are no signs of infection. There has been no apnea, that's cessation of breath. Their blood level is okay. You must have done all the blood work. Their kidney function is okay. You've checked it. There's no jaundice. Even if they had jaundice, it has resolved, right? So you're looking out for all these things. And we always prefer that they would have started their vaccinations while still on admission before they go home. So you have to make sure that this child has checked all these boxes before you even begin to think that, okay, this child might be going home. I don't know if I've left anything out, but basically these are the issues. Weight gain, feeding, respiration, is their blood level okay? Are all their vitals stable? Yes. Temperature regulation and all that. So it's a series of graduations. They graduate from this to this. Sometimes we blow balloons with the gloves and say, oh, baby, this is out of the incubator, and the moms are happy. So it's always like a mini celebration when they graduate from one stage to another. So eventually, with all this, we tie them down and say, okay, baby, this has graduated from the NICU, and then they're going home. It's always a beautiful day.
So but then at this, are there things that do we make it a point of duty to teach parents how to care for their babies when they get home?
Well, yes. Chief said follow-up. Follow-up is very, very vital. For every child has been admitted, even on the pediatric ward, for the older children, there has to be a follow-up. There has to be. For the preterm, their follow-up is longer, and they even have their special clinic. So what happens is, they come for follow-up because they have long-term complications. Not all of them, but some of them have long-term complications. So you want to be able to pick them early and refer them to appropriate specialty, or give the required therapy if the onus lies on you. Now, follow-up is very, very vital, and I can confidently say that they actually stick to it. Very, very rarely do you see any of them deflecting from follow-up. If they have to deflect, they inform you. Maybe they're moving to another state, and then we now write a referral. But they always stick to their follow-up, and it's always beautiful because we have their records. And by the time some of them, we follow them up until 2 years, some up to 3 years before they graduate. And it's funny because when you see them, they look nothing like what they were when they were in the incubator. So it's always lovely to now see them, and then the mothers. Sometimes I recognize them from the mothers. I don't recognize the babies sometimes because they change so much. They have cheeks, and then unfortunately, some of them have some, complications like cerebral palsy, where it's an injury that happens to the brain. It's not progressive. It doesn't progress, but then it's permanent. Okay, so they need a lot of support. Sometimes we give them medications that help with the brain development and all that. And some of them have learning disabilities, language delay, and all that. So follow-up is very, very vital. Well, in terms of support groups, that's something we're really lacking here. And I remember, I think when we talked about it the last time, I was like, I wish there's a few handles on Instagram, like the Niger Preemie Mom. Like, I think they're trying to begin this like movement. In other parts of the world, again, I would like to say is these things are there. They have breastfeeding groups. They have support groups for almost everything. They have support groups for mothers that have lost their babies. Because I always say it, the best person to explain things to you is somebody that has walked that line. So I, as a doctor, I've never had a preterm baby. There's only so much I can tell a mother, but I can't relate on that level of experience. So the best person to talk to her is somebody that's had a preterm. And guess what? Sometimes when we tell them things, they feel, oh, we're just doctors, we're just trying to. But once they hear it from, you see what happens with these mom communities on Instagram. Most times you see something that's a clear medical case, but they're asking other mothers on the platform, please, have you experienced this before? Because they rather take it from
a clear medical case, and then they're in the hospital as
yes.
well.
Yes.
Asking the question.
And they're asking mothers on the platform, have you gone through this? How did you manage, So support groups are very, Chief is talking because he's based in the UK, he's practicing in the UK. So he's throwing all these missiles at us, all this ultrasound and because he's practicing in the UK, right?
Okay.
But the thing is, support groups, I always say it, like support groups, and there's only so much I can tell them, but support groups are key. And you know what we even do? Most times, because in the incubators, you have a lot of preterm. So most times I link them up. I'll say, Mommy, this, please talk to Mommy this. Like, tell her how you started. Yeah. And most times you see them forming friendships there in the NICU, and they're exchanging numbers. And when they're going, some of them will be hugging and crying. Like, we've been here for like the past 3 weeks together and you're leaving. So most times we link them, and you see this friendship begin to form, and this sisterhood, because it's very key, it helps them. You see this mother kind of, no, don't worry, even my baby started like this, and now she's, see her cheeks, and then it actually helps them.
But then it's not really a big deal. It's a group. I think we had in Enugu, we had a sickle cell support group, like, so they would meet, I think for convenience, maybe a little bit after their clinic, their clinic days and things like that, for parents of children who have, sickle cell. So you said Niger Preemie Mom.
Niger Preemie, yes.
Yeah. Okay. So hopefully more will start, and then I think it's a really good thing that you try and because you have these you have the contact details, and then you have you know all the parents. So yeah. Okay, so I think we have a very short time left. I don't know, would you be able to come back just for a short time because there are a few more questions I would like to ask, just in case it goes out. So I wanted to find out from you, very, 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 very important, because even for children who are full term, apparently the signs that the baby shows when the baby is hungry or when the baby is satisfied is very, very different for a preterm baby. Can you please shed a little more light on that, especially for parents who are listening?
Well, the truth about that is, I don't know about the let's say the scientific, evidence of that, because a lot of times, like during our training, we weren't taught any of that, but because I had interest in all this on how to explain to mothers, you have cues about when the hands are open and when the fist is closed. When it's open, the baby is hungry. When it's closed, the baby is full. Kind of saying like, I want this, and I don't know if I'm having it the other way around.
Is that
But
the
then
other way around?
the other way around. So when it's
When the
like
baby is
this, the baby
relaxed.
is yes. When the baby is relaxed, the baby is full. So the thing is, the scientific basis behind that, I'm not too sure because it's not in the literature, it's not in the books, but then it's there because I feel before things are put out there, a lot of research, and then it probably works. I tried to look out for it in my own son, but it wasn't there, right? So for Chief is asking for primitive reflexes. Well, I don't want to really. That's what I talked about. Their reflexes being premature. That's why a lot of things. Primitive reflexes. We have things like all the Moro's reflex, the Graft's reflex. Moro's is when whenever you pick up a baby like this, and you try to, you just try to drop them, and then they stretch out their arms. So
Yeah.
in the preterms, you see that it's not the complete thing. They'll
There.
stretch out their arms, bring it to the middle. Sometimes they even say like their thumbs come up and then they cry. But then the preterms is incomplete. A newborn baby, fathers get really excited when you put a finger and then they grab your finger and they feel, oh, he knows me. That's actually just a primitive reflex, right? Then things like the sucking reflex and all that is actually primitive. Then the rooting reflex. Now that's another one because for a newborn, if you notice, there are videos out there online where you see a baby is born, the mother just holds the baby close and the baby begins to tilt the head towards the stimulus. You just put something like a finger, a clean finger, or just the tip of the nipple, and the baby would begin to tilt the head towards that breast. That's a primitive reflex. And then these newborns, their reflexes are not very, very well formed. They're not mature enough. So they don't really have that reflex. And then for normal babies, sometimes when they're hungry, apart from the hand sign, they tend to put their hands in their mouth. You see them wave as if they're trying to suckle on the hand. Some of them just cry, like basically trying to communicate that I'm hungry. But a lot of these things could be absent in the preterms. So most times we don't ask the parents to wait for a cue. We ask them to feed them on a schedule.
Okay.
Especially for the preterms, we tell them to feed them on a schedule. For term babies, most times it's okay, you can feed 3 hours, but for preterms, we tell them to feed them every 2 hours. So we don't ask them honestly to wait for any cue in preterm.
Okay. We have 10 minutes more. There's another question I wanted to ask about. Okay, so immunizations, are any of them delayed?
Well, the truth is, even if the child is preterm, if that baby's weight is up to 2.5 kg, they continue their immunization as if they were a term baby. If it's up to 2.5. Now, if a baby is born preterm and that baby is less than 2.5, especially less than 2 kg, we ask that it is delayed. So most times, obviously because we expect that they'll be in the NICU, so the timing is that you begin a month after or when the baby is being discharged. Because it is assumed that that child would have stayed for a number of weeks. Or if the baby gets to 2 kg, before you can begin the immunizations, there's no exemption to say, okay, don't give this particular vaccination, They can be given all because studies have shown that they tolerate it and then they mount the responses as well. So the same thing applies for term infants, not just, it's just about the weight really. We look at.
Okay. So please, we're going to go away and then come back again. Thank you so much, Dr. Mims. As in, this has been so informative. Please, guys, come back. Yeah. All right.